Is induction necessary with gestational diabetes? Hi, I'm Kathy Fray and I'm a semi-retired senior midwife and a best-selling maternity author, and welcome along. So with gestational diabetes, there's a whole general kind of feeling around the place, oh, you have to be induced. Well, firstly, nothing has to happen to you. It always requires your informed consent. But let's go through the gold standard best practice guidelines, and we'll take it from there. All right, so NICE, or the National Institute for Health and Care Excellence, put out the NICE guidelines in 2015, which they updated in 2020, and they really are the current gold standard around the world of what is best practice. And this is their wording. If you have gestational diabetes, you should be advised to have your labor induced before 41 weeks of pregnancy if you have not had the baby by this time. And during labor, which means you're at least 4 centimeters dilated and you're having regular painful contractions, then your blood glucose should be measured at least every hour to make sure it stays in safe levels. So there we go. That, ladies, is the gold standard. Now, what you will find is a lot of variation on that with obstetricians all around the world. And most of that is because of their habitual practice of what they have always done in their practice, or what is the routine culture of their practice, or what is the normal thing or common thing occurring in that hospital. But that's wrong if it's not following the actual global best practice guidelines. But trust me, there are many obstetricians out there who are not following those guidelines. And unfortunately, there's no real repercussions for that, because there's no reflection process or peer panel that goes through these things with them and says, why did you induce that woman? Why are your induction rates for gestational diabetes so high? Nobody's questioning it. So they just do what they do, and women accept it. And, they have that God syndrome often of, well, the doctor knows best and I don't want to take any risks and I only want to do what's best for my baby. We understand that. And that's called following the gold standards of best practice. Okay. Now, there is a bigger picture to also consider with it. Now, if you have any comorbidities, so let's say you are advanced maternal age, over 35, you have preeclamptic toxemia or gestational hypertension, there is growth restriction concerns on your baby and IUG, potential STA or IUGR baby. If you've got any of these types of things going on, that's a whole different ballgame. Okay, because you have to look at the whole big picture. What we're talking about is inducing at 41 weeks is for a healthy, normal woman with a healthy, normal pregnancy who has no other risk factors or complications. All right. Now, also what needs to be taken into account is the sort of level of how impossible the gestational diabetes is proving to be to maintain normal blood sugar levels. So say, for example, if through diet alone, just modifying your diet, you're able to pretty much stay with, keep your blood sugars within normal range. Well, you've got a really mild kind of situation of gestational diabetes. But let's say, for example, if the diet controlled it for a while, but then that became impossible, and then you went on to metformin tablets, but then they couldn't deal with it successfully, and now you're on injected insulin, and things are progressively escalating and fulminatingly worse outcomes of gestational diabetes. Well, then that's a different situation too. So so long as your blood sugar levels are able to be maintained as within normal range most of the time, then that is not impacting your baby. What impacts your baby in gestational diabetes is when your blood sugar levels are not able to be maintained as normal and you become hyperglycemic or you've got high blood glucose. So a baby that's getting exposed to that high blood glucose, because it does cross the placenta, so that's how it impacts the baby, because it crosses into their bloodstream. So your high levels of blood glucose or blood sugar then crosses into their bloodstream, so it gives the baby high levels of blood glucose or blood sugar, which means that they have to then produce higher levels of insulin to be able, from their little tiny fetal pancreas, to be able to cope with those high levels of blood sugar. And that impacts the baby. And the two particular ways it impacts is, firstly, that the insulin and the high blood glucose kind of acts as to inhibit the maturing of the surfactant in the lungs of the baby. So those babies can be born with a bit of respiratory distress because they don't have the same levels of surfactant in their lungs that they should have. And then the other consequence of all that exposure to all that high blood sugar is that the insulin acts as a growth promoter, almost like a hormone impact, and it will make these babies grow unusually large, and they get what we call a cherub look. I mean, babies have very little neck anyway, but these guys have like no neck. They look like Buddhas. They're like and yeah, so a little Buddha baby, or we call it the cherub looking baby, big, chubby baby that's got these immature lungs. So they can really struggle. And after they're born, what happens is that because they suddenly lose that sugar rich supply from the maternal blood, with the sugar crossing the placenta, because they lose that, but their body has still got those high levels of insulin running around it, so those babies can quite quickly, within the first few hours, go into a hypoglycemic situation where they get very low blood sugar. So that's why we monitor the baby's blood sugar glucose after it's born, every few hours, until we see 12 hours of normal. Once we've seen 12 hours of normal blood sugar levels, that's good. The baby's out of the woods. It's all fine and tickety-boo. And so typically any woman that's had even the most simplest, straightforward birth should be staying in the birth centre or in the hospital for the first 24 hours to have that regular monitoring of her baby's blood glucose. And then after the birth, 6 weeks, 8 weeks after the birth, then the woman should have a repeat GTT, glucose tolerance test, to just confirm that gestational diabetes is completely gone, and that she hasn't actually got type 2 diabetes. So that's everything. But if we go back to answer the primary question of this particular video topic, so these are the NICE guidelines, the National Institute for Health and Care Excellence, written in 2015, updated in 2020. They're the gold standards, best practice that should be applied all around the world by all obstetricians. If you have gestational diabetes, you should be advised to have your labor induced before 41 weeks of pregnancy if you have not had your baby by this time. Ta-da! And just bearing in mind, if you have comorbidities, other complications, then that's a different situation. All right. Want to wish you a wonderful rest of your day, rest of your week. Right, bye, everybody.